A very warm welcome to all of you. I'm Stephen Willett. I'm a GP and clinical lead in substance misuse in Nottingham, and I'm chairing this webinar tonight on behalf of SMMGP, and it's made possible by an unrestricted grant from Althea, which we're very grateful for. So, tonight, as you know, is medical cannabis and anxiety. This is the second in our series, and it's, I would say, very timely given the amount of Brex anxiety in the UK these days, not to mention the years of austerity. There's much debate on the subject of cannabis, particularly medical, since the UK's government's landmark ruling just a year ago, which allowed limited prescribing. But we have so little of experience of it here, with only a handful of patients actually getting it prescribed. So tonight we'll look at the evidence base, including prescribing regimens, and then a clinician's experience of prescribing medical cannabis for anxiety. That clinician you see before you, Dani Gordon. She's a medical doctor, a leading expert in clinical cannabinoid medicine after treating thousands of people in Canada, where she specialized in neurological disorders, chronic pain, and mental health conditions. She speaks internationally on cannabinoid medicine, and in 2018 moved to London. She's also the vice chair of the UK Medical Cannabis Clinicians Society. Hope you know. So, no housekeeping, you know where the toilets are. What's the format of tonight's webinar? Well, Dani's going to talk for 20-25 minutes. There'll be an extended period of Q&A after that. And the webinar is being recorded, so you can watch it again. We'll give you details of how in a follow-on email. But please, importantly, put your questions or comments in the chat box on your screens, and I'll do my very best to put them to Dani at the end of her talk. There are lots of people watching, so we hope to ask all of your questions, but apologies if we don't directly get around to yours. First of all, though, question for you. Okay, in fact, two questions. If we could have the first one, please. So, get on and answer as quickly as you can. This is interaction time. It'd just be useful for us and Dani to know who you are. So, I'll give you 5 seconds more. Okay, there we go. So, as you can see, we're a glorious mixture. Just over a quarter doctors, same with nurse pharmacists, quite a few key workers. We were expecting a few patients, but we'll see. And some others, sundry others. I wonder who they are. Thank you for that. Now, the second poll. It's right on topic. So, that's the question. Do you think that medical cannabis can cause mental health problems? Yes, no, don't know is fine. Okay, give you another few seconds for that. Great, okay, and if we can have that one. So, a significant, the largest group think that it could cause some mental health problems. So that's a very good reason for having this webinar here tonight. And we're going to be, and if we've left any questions unanswered, make sure that you put those to Dani. So without further ado, it's time to hear from Dani, looking forward to it. Dani Gordon with medical cannabis and anxiety. Thank you very much.
Thank you so much for having me, everyone. And hopefully we'll be able to dispel some myths. And, you know, like most things in medicine, medical cannabis is tricky, but I've been using it successfully in my medical practice for years in Canada. And since the legalization, I've been training UK medical cannabis doctors as part of one of my roles is the vice chair of the nonprofit society, the Medical Cannabis Clinician Society. And actually this morning I was just at UCL speaking on the Masters of Mental Health program on this very topic. So I'm really excited to be doing another one this evening on the same topic. And let's get started. Okay, now, there we go. All right. Just getting used to this advancer here. So just to set the scene a little bit before we get into it, but cannabis has been used in pretty much every ancient old world culture for thousands of years. That's a picture of me in India, where I've spent a lot of time. In addition to being a conventionally trained medical doctor, I'm also an integrated medicine physician, and I also teach my patients things like MBSR, mindfulness-based stress reduction techniques, and I also do herbal medicine. And I've done that for the last 10 years, adding cannabis to my practice almost 5 years ago. And even in the 1800s, we have medical texts from the Victorian era where tinctures of cannabis were used for the treatment of anxiety, depression, and insomnia. So, for example, when you submit an academic paper in the UK talking about medical cannabis, as I did recently with a colleague of mine who's a UK GP physician who I'm mentoring and who's now trained in cannabis, once the GPs can finally prescribe here, we hope, we received some interesting feedback from the peers who have now accepted our study, but they said, well, there's no precedent in the medical past for the use of cannabis as a medicine. Well, it's absolutely wrong. There absolutely is. And cannabis was actually a medication that was perfectly reputable until 1971, when it was removed from the pharmacopoeia in the UK, and around the same time in the US and Canada. And that had more to do with politics than it had to do with the actual plant. I'm not going to bore you with the details, but it's something you can look up if you're interested. And when I first started getting interested in cannabis medicine, it was because of my patients. Even though I had a postdoctoral fellowship from the United States in integrative herbal and botanical medicine, I really was against cannabis, believe it or not. And I had a lot of myths and preconceived notions around the plant. And these were things that I had to start deconstructing using scientific methods. So this is something quite amusing you can look up on your own, but there was a very successful propaganda campaign that was quite a racist, anti-Mexican, and anti-Black and mixed race campaign in the 1920s against cannabis. And it really portrayed cannabis as a very dangerous substance. It was, causing people to go into these spirals of madness and insanity, and they were doing these drug-crazed, heinous crimes, committed all because of cannabis. And the New York Academy of Medicine in 1944 took a look at this, and they said, what's actually going on? Is this substance actually as harmful as it's been reported? And they found that it was not causing heinous crimes, hysteria, or any of the other things it was purported to. And they submitted the report, which was the most extensively researched report really until the modern day, until very recently. And it was just ignored, basically. So we got rid of it in 1971 here in the UK. And it all makes sense that, we don't really know how to use this as medication, because in medical school, when I was in medical school 10, 15 years ago, I graduated over 10 years ago now, we didn't learn about the endocannabinoid system, which is basically one of the most important body systems for balancing our brains and our bodies. It's a regulatory system that helps maintain homeostasis. So we say it's the eat, sleep, relax, protect, forget system, because it controls all of the things you see on your screen. I'm not going to go into detail, but again, this is, one of the most important balancing homeostatic systems in our bodies. And just like any other system in the body, it can go wrong. We have receptors for the endocannabinoid system. This was discovered in 1989, these receptors, and really the endocannabinoid system was moved from theory in animal models to, yes, it definitely exists in humans in 1990, although it's still very much not taught well in medical school today, 30 years later for some reason. So these different receptors for cannabinoids are actually meant for our own endocannabinoids that our body makes. So our body makes two chemicals that fit in these receptors, just like other systems in the body. And it just so happens that plant cannabinoids can also fit similarly into our system. Now, I know you guys learned about this last time. I'm not going to go into detail. But the most interesting thing, for me anyways, is that we used to think, when I first started doing this, that CBD was sitting in these CB2 receptors. But now we know that CBD is kind of going around and kind of, I like to say, it's sprinkling its magic all over the system as an overall modulator. It doesn't bind tightly to either CB1 or CB2. That's very different to what THC does, which it binds more preferentially to CB1, which basically leads to symptoms or effects, I like to say more than symptoms, of intoxication, but also can have a therapeutic effect, especially when combined in specific ratios for certain conditions with CBD and other cannabinoids in a medical product. So conditions like insomnia that are refractory to treatment, PTSD, for example, anxiety in a very, very tightly controlled amount, which I'll get into, and for chronic pain. And these are all the ways I use it. Try to not get rid of that. Okay, there we go. So I'm just going to talk about a few of the players, but before I get into that, I just want to touch on the sativa versus indica debate. So the way that cannabis products, medical cannabis products, were labeled when I first started doing this, it wasn't too long ago, just a few years ago, was indica strains versus sativa strains. And now we understand that because the genetics of modern cannabis plants have been crossed so many times, they're all relatives of each other. So you can no longer tell by looking at a plant whether it's an indica or sativa. And really, it's more about what's called a chemovar. And what that means is, what is the cannabinoid makeup, besides THC and CBD, of that strain? And what is the terpene makeup? So I'm going to tell you what those things mean. But basically, everyone's a relative of each other. Everyone's married their cousins in the genetics world of cannabis. So now we have to look at the chemical profile of a strain to see what effect it might have on someone. So mostly it's about CBD and THC from a very broad kind of brushstrokes perspective. But actually, especially in mental health, what I have found is the other minor cannabinoids and the terpenes all can make a real difference. So I'll tell you what I mean. So just so we all get an understanding before we go into the chemicals a little bit that are important for anxiety, cannabis starts off as a mother compound, which is this thing called CBGA. Anything that has A on the end is an acid, and when you heat the acid gets dropped, and it turns into basically the non-acidic version of that precursor. So CBDA becomes CBD, THCA, which has therapeutic qualities, and I use this by itself sometimes, in addition to other things, becomes THC. And then THC breaks down into something called, well, a few things, but the main one is something called CBN. So even CBN, which is a breakdown product of THC, can have therapeutic benefit in anxiety and potentially in the evening for people who want to calm down and rest and helping with their sleep. CBN is something I'll get back to on the next few slides. I'm just going to get rid of this little, there we go. Okay. So CBD stands for cannabidiol. I call it the anxiety superstar. And this is being a bit simplistic, but really CBD is quite safe even in very, very large amounts. I'm talking 1,500 milligrams. If you took 1,500 milligrams at once of CBD, basically nothing bad would happen to you. It's non-intoxicating, although it is psychoactive, which means it crosses the blood-brain barrier and it affects the brain. So SSRIs, for example, are also psychoactive, but they do not cause, as we all know, intoxication. CBD is safe. It's the same. It's also anti-inflammatory. It's neuroprotective, which is interesting, especially from an integrative medicine view of depression, which, as we know, often overlaps with anxiety and addiction, because depression seems to, in some cases at least, be a final common endpoint, and in many cases may have an inflammatory component in the brain, something we still do not fully understand. And CBD, as I talked about in the slide about the receptors, it modulates or kind of balances your whole system. You can think of it this way. rather than sitting in one receptor site. And it does this through a number of different activities. So it basically does things with your serotonin receptors, especially your 5-HT1A subtype. It affects other things like your orphan receptors, basically receptors we don't know exactly what they do yet. It has a cascade effect on inflammatory pathways, and the list goes on and on. So as far as medical cannabis, high CBD, low THC medical cannabis strains and products, this is the base of my therapy for anxiety disorders, and also can be used to buffer potential THC side effects. So as we know with medicine, it's very rare that I have someone come to me for a pure anxiety disorder. Most of the time it's someone who has chronic pain, anxiety, depressive disorder, NYD, chronic insomnia, and a list of other conditions, chronic in nature, that are difficult to treat. That's usually what they're coming to see me, because they've often failed simple interventions. So sometimes if they have really bad chronic pain and they have really bad insomnia and they're on a whack load of medications, and I'm working with, say, their psychiatrist to decrease some of those medications because they're not really being that effective, then we add THC as well. CBD, from a botanical medicine point of view, I think of it as what's called an adaptogen. There's no drug equivalent of adaptogen in Western medicine. So when I first learned about this in my integrated medicine postdoctoral fellowship, it was really hard to wrap my head around because I'd come from a Western medicine background and I thought it was very woo-woo. But it's actually quite interesting because these things called adaptogens are actually just chemicals that plants make to help them adapt to stress, because plants can't go anywhere. They have to stay in one place and fight the stress. They cannot run away. So they make these compounds that help them basically adapt. And it does things like modulates the adrenal response in humans. And why do these substances work in humans? Well, the same reason that other botanicals work in humans, because we have systems that can use many chemicals from nature, including half of the drugs that we prescribe come from natural compounds, botanical compounds. So in order for something to be an adaptogen, it has to be non-toxic, non-intoxicating, and helpful with stress adaptation in the realm of chronic stress. And CBD can be thought of in this capacity in many ways. It's very safe. It's very safe in overdose. It does not cause intoxication, and many people report that it does help them manage their stress. And we have quite decent evidence clinically and also in the literature, which I'll share with you, that CBD does help with anxiety. Okay. Next is THC, the one that everyone knows about. So in addition to being an intoxicant, especially when used on its own or in recreational, very high THC, low CBD strains of cannabis, THC has a lot of medicinal benefit. And it's a sedative if you use certain strains, but not always. It can also be uplifting, and it can help someone with ADHD in very small amounts to focus. Really interestingly, something I never thought possible when I first started. It's also an antispasmodic, so people who have IBS, for example, inflammatory bowel disease, a lot of gut motility problems, sometimes they get relief from THC. It can also, at small doses, be an anxiolytic, meaning decrease anxiety, or it can be anxiety provoking. And that's because of what's called the biphasic response to THC, which is dose dependent. Basically what this means is there's a bell curve response to THC. Everyone's a little bit different, but basically when you get beyond someone's sweet spot with THC, the THC can actually provoke anxiety. And this is sometimes an issue with my patients who have been self-medicating with recreational cannabis in the case of Canada, or in the case of the United Kingdom, black market cannabis that's very high THC. They are often trying to self-medicate an anxiety disorder, and their initial response may be a decrease in their anxiety, but they may be having an anxiety rebound from the very high THC. And that's one of the things that we do with cannabis medicine, is we actually are also doing harm reduction. So if someone's using a cannabis product that is not medicinal, that is not tested, and that is not the right combination of cannabinoids for them, we want to really shift them. THC is also a very good pain reliever, especially for chronic pain, where opioids fail us, although they are very overused. It's also actually neuroprotective, so it protects the brain from trauma and stress. And that I find very fascinating, because we were always taught in medical school that THC was going to fry people's brains, it was harmful for the brain. That's not actually the case. It's also a muscle relaxing, the antispasmodic, that's actually a repeat. And even in small doses, it can be used in combination with high CBD in cases of treatment-resistant epilepsy in a very tiny dose, just to augment the effect you get with the CBD. I've also used it extensively for weaning people off opioids, and in my cancer patients as an appetite stimulant, and for treatment-resistant insomnia. Then we have CBN, which I mentioned earlier. It's the breakdown product of THC. So if you have a patient, for example, this is how I found out about CBN, by the way. Before we had all these fancy products on the market, there was, only a very kind of limited supply about 4 or 5 years ago on the Canadian medical cannabis market that we could prescribe. And I had patients coming in saying that their old cannabis flower, when they waited to vaporize after it was old, or if they vaporized it after they'd already heated it up once, it made them feel calmer but not as high. So I said, that is very interesting. And I started to wonder why. And the reason why is because these products have a higher concentration of CBN ratio-wise to THC when they're older. And CBN is only mildly intoxicating, so less intoxicating than THC, but it's more calming and more sedating for most people. Then there are the terpenes. So the terpenes give cannabis its smell. So terpenes are in every plant. There's terpenes in oranges, and anything that smells good or smells bad for that matter in nature, that's a terpene. And they contribute, we think, to what's known as the entourage effect in cannabis, or in botanical medicine, it's known as herbal synergy. One example is it's one called D-limonene, which is also in lemons and limes, and it seems to have both uplifting mood effects and anti-anxiety effects. Again, quite interesting that it can do both, but this is botanical medicine for you, and it's actually not uncommon. Then there's another one called alpha-pinene that may be helpful, we think, in reducing short-term memory impairment from THC, because it actually has anticholinesterase activity. So that is something that I use a lot of in some of my patients who might, have that as a side effect coming up for them. Then there's something called beta-carotene, which is a really good anti-inflammatory. And then we have myrcene, which is really relaxing and calming. So another really interesting thing that I found out was some of my patients were using hemp CBD at one point in the early days of hemp CBD. So again, hemp CBD is something you can get without a prescription. You can get it here in the UK without a prescription. It's not licensed as a medicine, so you cannot prescribe it. But basically, it's made from cultivars of the cannabis plant that are classified as hemp because they have less than 0.2% THC. So some of these strains have a lot of myrcene in them. So although they don't have a measurable amounts of THC, it can feel someone almost like a narcotic effect, and that's from the myrcene. So if someone's feeling too sleepy from a hemp CBD oil that they might be trying, then you might get them to change brands or look at the certificate of analysis for the product they're using and see if it's high in myrcene. Terpenes cross the blood-brain barrier, so they are psychoactive, and they might contribute to that uplifting effect of a strain versus a calming effect of a strain, and they're lost really easily when you store cannabis any way, shape, or form, but especially when you store it inappropriately. Okay, how am I doing for time? These are the possible delivery systems for CBD and cannabis. We stick to oral and vaporized, and normally oral. I'm not going to get into this. This is another thing that people are interested now in, using CBD instead of alcohol for entertaining, but we won't go there today in interest of time. So cannabis and anxiety. So when I choose a cannabis medicine product for someone with anxiety, if I'm in Canada, which I still keep my practice there going very part-time, although most of my work is here now, I have loads of choice in Canada. So I can choose dried product like a flower that someone puts in a vaporizer. To use, I can choose a variety of oils that have a variety of different components. So I can say things like, okay, I want to look for a product from a company that's having calming terpenes and, really be choosy. But in the UK right now, most of the products we're going to see are going to be in oil form, so oral. So really it's about choosing a high CBD and a low THC product. So you can start with a ratio of about 20-1 CBD to THC. And that's kind of as granular as you can get right now. That's still the most important part for anxiety, is avoiding high THC, especially inhaled high THC, because it can really make people get more anxious. My patients who have a mix of anxiety and depression, sometimes I do use a small amount of THC, again, in specific strains to help them with their motivation and their energy levels in the morning. Although that may sound counterintuitive, considering, again, we were taught in medical school that all cannabis causes amotivation syndrome. Again, not the case. It's dose dependent and product dependent, and depending on the ratios of cannabinoids. So I'm obviously picky about the ratios of cannabinoids, and medical cannabis in general is the products you're going to see. They do offer high THC products, but generally I would use those quite sparingly, and at night, for example, for sleep if I needed them. So cannabis and sleep, again, I always say to people, sleep is really a 24-hour hyperarousal problem. It's tightly linked with anxiety. People with anxiety often do not sleep deeply. They might have trouble getting to sleep, or they sometimes have fragmented sleep. So obviously you remove caffeine and all those other things, because I don't believe cannabis medicine is a cure-all for anything. And it's just another useful tool in my toolkit. So I'm not just giving patients cannabis, in case anyone was wondering. But after you do all those other things and they want to try something instead of their Zopiclone or their benzodiazepine, sometimes I do use a small amount of a THC indica oil. Sometimes I mix it with CBD, especially if they have certain conditions, if they have a cardiac condition. Sometimes I don't. Sometimes I just use a microdose of THC. High CBD on its own can sometimes promote wakefulness in some people, although other people do say that it helps them get to sleep. So it really is person dependent, and it's likely dependent on if their insomnia is stress driven. I find if their insomnia is stress driven and is part of a lifestyle change that we're working on, sometimes CBD can just help them slow down and calm down. But it can promote wakefulness. I just mentored a case here in the UK with a psychiatrist that I'm mentoring here for cannabis, and she was even finding with her patient that a high CBD and then even a 1-to-1 ratio was still promoting wakefulness in this patient. So I said, well, let's try the high THC in a microdose, and it worked like a charm. And this is someone who's very treatment-resistant insomnia. I just want to make sure I get to my case. For stress management, cannabis and CBD, with THC, less is more if it's added at all. I always say in my practice that people always say, oh, cannabis is a gateway drug, but I find it's actually a gateway sometimes to meditation. So a lot of my patients are so anxious that they cannot do things like engage in meditation or mindfulness-based stress reduction, or even watch a mindful breathing exercise, or engage in a CBT session, which are all things that I think are very valuable. So if we can get them to calm down a bit, which is how I use a high CBD cannabis product, then we can often get them in the zone to do these other things, and we can also give them a quick win. Because if we don't get someone a quick win who's been chronically anxious and gone through every medication and seen every specialist quickly, then they will lose faith. This is at least my experience. So this is a gentleman I saw in clinic, and he'd been referred to me from his psychiatrist, who was basically really wanting to just add cannabis to this person's management, because this patient had been working with this psychiatrist for many years, and they'd also seen other people, and it was a very, very good psychiatrist actually, and they'd really exhausted all of the options. He had tried every drug, every combination of drugs under the sun. He'd gone and got a few other assessments to make sure they had the diagnosis right. I mean, it just went on and on. And they'd also tried psychology visits. They'd gone to see a naturopath. They were already taking the high dose vitamin omega-3s and the B6 and all these natural things. It just really wasn't making that much difference. He was really stuck. And he was, being stuck was making him more depressed, because he was feeling like he was really losing hope of ever getting better at this point. And he wasn't sleeping. He hadn't slept well for 20 years, he said. He was taking sleeping pills as well at the time, Zopiclone. So, okay, we said, well, let's try some some cannabis. So we put him on a high CBD oil during the day. We slowly titrated up the dose. Then at nighttime, we started with a 1-to-1, like a balanced CBD and THC oil, an indica dominant, so it's a very calming strain before he went to bed. And then we just kind of slowly titrated that up. And at 6 months, he basically felt the best he had in over 20 years. He said he slept for the first time normally for the first time ever. He felt normal in the morning for the first time in his life. He said before he didn't actually realize how bad his sleep was because his brain had gotten so used to that awful run over by a truck feeling when he woke up that he was just shocked by the difference it made for him. And of course, we know that, disrupted sleep really can cause depression markers to start lighting up in a brain on a PET scan of someone who is not clinically depressed if you sleep deprive them long enough. So this was really quite life-changing for him. He had no side effects from his medical cannabis, and he was retired already, but he started picking up golf again. He started exercising, he lost some weight. He says that it saved his marriage because his marriage was really failing for about the last 10 years. The second time he came to visit me, he really kind of opened up, and he said, this is really kind of ruining my relationship because my mental health is so poor. So he, this really did change his life. And, before I go on to that next slide, I guess I should say that I haven't cherry picked this case. This is a regular occurrence. And this is what has made me an advocate for offering this option to patients, especially who have tried everything else, because, what I always say is no one's ever said when I gave them an SSRI, this has changed my life, but it happens in my cannabis medicine integrative clinic every single week, not just with mental health, but with many other conditions. I'm not curing people, but I'm giving them their life back, and it is completely life-changing for them. So the take home from that case is CBD and THC can work together, and they do work together. And even just adding a tiny amount of THC can reduce the amount of CBD that you need to control a wide variety of symptoms, including anxiety. And that's why some people will potentially come to you if you're a doctor watching this and say, well, I've already tried that hemp CBD, it didn't do anything. Well, medical cannabis still might be worth a try for them. In fact, I think it is worth a try. I've had many similar cases where the referral node has been CBD non-responder. Well, oftentimes that's because they didn't do it long enough. They didn't get up to a high enough dose, and they need to add a little bit of THC in there to go for that entourage effect. So they're not spending a fortune on the high CBD one. So, it's all about cost reduction as well, which is still a massive hurdle in this country. We need to really work on that because in Canada, this is costing my patients, around 100 to 150 pounds a month. It's not covered as a medication. We don't get our medications covered in Canada with our system, but it's affordable. And those patients who are under the poverty line, or they're war vets, or they have PTSD and they come from the police force, I have many of those patients, they get it covered. So in the UK, the prices are still very, very high, and we need those prices to come down for this to be really an option for patients. And I think that will come in time with more companies entering the market and hopefully just the whole conversation opening up. I think relevant to this, especially since this is an addiction substance misuse group, is what do you do with patients who are using high THC products? Another case I am mentoring right now for a UK physician is someone who is prescribing in a case where the patient was already using black market cannabis, and they have very severe chronic pain, and it's real. They're not making it up. They have a lot of spinal intervention, and that's what happens. And but they're using a lot of high THC. So what do you do in these patients who come to you with already, quote unquote, knowing more than you and wanting these high THC prescriptions? Well, I have an approach to these patients, which I learned on the front lines. And the first thing I do is we swap out I actually swap step 1 and step 2 usually. So usually I'll swap out the high THC flower that they're using on the recreational market for a balanced strain and put that in their vaporizer first. So I reduce the amount. I want to cut the amount of THC they're using right from the beginning, but I don't want to cut them off completely. And then usually what we'll do, if I can get them to agree to it, is we'll try a THC holiday or a washout period after we do a wean, because what we do is we reset the receptors, and then they're really sensitized again to THC after, say, 5 days without it. So the THC works better at lower doses. And then we add a high CBD oil product to get that anti-inflammatory effect. And how I sell patients on this is I say, well, do you want to save money with your cannabis, and do you want it to work better with less side effects? And most people say yes, because if they're coming to me for a medical cannabis prescription, they can get it probably cheaper or without a prescription. And trust me, in the UK, the black market cannabis is much cheaper than a prescription. So this is, if they're coming to you for a medical cannabis solution, they're going to be open to this, because otherwise they'd just be getting it much cheaper themselves on the black market. So people always want to know what I do with patients. And as far as protocols go, as far as published protocols go, there's not much. There's a lot of reasons for this. Some of them are scientific, some of the reasons are industry driven. But I can tell you what I do. Everyone's a bit different, depends on what product you use, but generally speaking, broad brushstrokes, you really can't go wrong with starting with a high CBD oil for daytime and then adding a microdose, 1 to 2 milligrams of a THC in an indica or high myrcene blend if you can get it for sleep or severe night pain. I always use some CBD to buffer the THC. I never just give someone high THC. Some physicians in Canada do that. I don't believe in it personally. I'm very research driven. And sometimes I do add in vaporized products using an herbal vaporizer for acute rescue symptoms if they need. But generally speaking, for anxiety, especially, I keep it as oils and capsules. So this is, again, just a general starting regimen, not necessarily for anxiety, but in general for the average patient I see, which is a gross generalization because I do see so many different types of patients, and I have more complicated algorithms than this based on more specific cases. But really, if you stick to these guidelines, you're not going to hurt anyone. It's very, very safe, and just when in doubt, use the start low, go slow approach. Start with high CBD, low THC, titrate up to symptom benefit, symptom reduction, or to side effect tolerance. If you have THC side effects, I have a few options. Again, I have an algorithm for this, but basically you have a few options. I usually try one at a time. You reduce the dose, you try a different strain, you add in more CBD to counter the side effects. And there's this drink that some patients swear by, which is lemon zest and black pepper. There's mangoes, some people say too, that have the opposite effect. The reason why these things have an effect on our endocannabinoid system is they contain terpenes as well, which may have either a potent potentiating effect or basically a anti-potentiating effect on THC. But not a lot of research studies on it, so more of a patient-driven thing. I'm just gonna skip through this, but generally it's well-tolerated THC when you use small amounts that we use medically. Again, don't have a huge time to go through, but basically the take-home is avoid THC in pregnancy and breastfeeding. From all the current research, CBD only remains unclear. In zebrafish, it seems no teratogenicity from CBD. And we don't know for sure how CBD affects prenatal development, and we have to take it into consideration. So for example, if I have a patient on CBD for their anxiety and they've come off of all their other benzodiazepines and their SSRI, and they're really happy with their control of their anxiety just with CBD, which happens in my practice, and they get pregnant, I still have to tell them that I have to advise medically for them to come off their CBD, their medical cannabis during pregnancy, because it still has a little bit of THC in it, and it's an unclear category, an untested category in pregnancy. So it's more, to be honest with you, to protect myself against medical legal risk than anything. I have had patients say, I understand that, but I'm going to go against medical advice. I'm going to get my own CBD in pregnancy, continue taking it, because I think I've informed myself and I don't want to go back on my other medication. And they've done that and they've had a normal pregnancy and delivery, and so far so good, but we just don't know. So I can't advise patients to continue in pregnancy at this point, although it seems pretty low risk. These caution areas are basically mostly for THC because of the cardiotropic effect of THC. Doesn't mean you can't use it in these areas. I have, very cautiously, working with a cardiologist if it's a cardiac issue. People always ask my approach with cancer patients because, you know, anxiety is something that cancer patients go through for obvious reasons. And I think, you know, cancer is very tricky. You know, I don't sell cannabis in any way, shape, or form as a treatment for cancer because we don't have enough evidence for that yet. But we sometimes use it to help with their side effects of their treatments. And I have had patients who I don't think would have got through their chemotherapy without a little bit of medical cannabis. But, you know, there are potential risks. And unfortunately, I think that would need a whole webinar to go into all of those things. The level of evidence challenges, I think you have to address it when you talk about cannabis. So there's only a few RCTs. Botanical medicines have hundreds of active compounds. RCTs were designed for the drug development funnel using a single agent pharmaceutical. It's not that drugs are bad, drug companies are evil, anything like that, but it's just the wrong tool for the job. So I think we need to move a little bit more broadly if we're going to speak about introducing things like botanicals, like cannabis, herbal botanical cannabis as a medicine, with looking at broadening the data sets into observational data. Right now, the observational data sets are really not good. They're just from the black market, smoked cannabis. So those are not very useful because it's very different than what we're seeing in the medical use category. So again, ideally, we'd have really good observational data from medical studies, medical cannabis patients. It's also obviously difficult to blind, especially with THC, because people know when they're getting THC. And there's hundreds and hundreds and hundreds of different strains. And even the product batch-to-batch variation can vary. There are lots of studies for the evidence in anxiety. Basically, the studies so far show that cannabis can reduce anxiety, especially CBD. Most of the studies are around CBD and anxiety. And these were studies done in healthy humans and a few done under stresses like public speaking, this kind of thing. In animals, the evidence is very strong for anxiety reduction, again for CBD. And these are some reviews. 2015 found that there was strong preclinical evidence supporting CBD as a treatment for GAD, general anxiety disorder, panic disorder, et cetera, et cetera. But more specific dosing studies are needed. I agree with that. But, you know, it's really, especially CBD is so low risk. And I've seen it be so helpful that I think it should just be used, in my opinion, not as last line either, maybe more, you know, first or second line in some cases. What else to point out to you here? I can give you some of those references if you want them. But basically, as we enter 2019, there's more studies being done on PTSD and cannabis, both on the CBD side and the THC side. That's another way that I use it, is to support patients with their nighttime PTSD symptoms. Again, it's not a cure, but I work with a psychiatrist who's treating them, and it can help reduce their nightmares that they get and help with their sleep so they can feel more rested in the morning, and they can break that cycle of hyperarousal and flashbacks and proceed more successfully with their treatment and their psychotherapy. So I always talk about the positive side effects that I've seen in my practice from prescribing medical cannabis. Some of them I mentioned to you already: increased uptake of mindfulness, MBSR, an enhanced physician-patient relationship, because these patients have been failed often by the medical system when they come to see me. I find that because cannabis is a botanical medicine and it's patient-driven to some extent when we're doing the dose escalations, of course under my care, but there's a lot of control they take over this medication, and for someone who's lost their internal locus of control, especially with anxiety, it's very empowering.
Dani, can I just jump in? We're getting lots of questions, and therefore just maybe wrap up in a couple of minutes.
That's it. That's the last slide.
How about that? You finish off.
No, you're right. I need to stay on time, but that's basically it. As you see, I get very excited about this topic. But yeah, these are some of the things I've seen in my practice. Instead of making people lazier, another thing I was really worried about with cannabis and amotivation syndrome, people actually return to work after being on disability for many years. They exercise more. A lot of my patients who are pre-diabetic, metabolic syndrome, and full-blown type 2 diabetes have lost weight. And basically, the reduction in pill burden and increased quality of life has made it a winner in my clinical toolkit. And thank you very much. And now I will take questions.
Well done indeed. And please imagine a rousing round of applause. I mean, that was so engaging. I was fascinated, and I think we could have all listened to you for 2 hours. But anyway, we've got a good selection of questions coming in. So let's go straight to this one here. Is medical cannabis seen as a long-term medication for anxiety?
That's a great question, and it's something I got asked this morning in the Masters of Mental Health course at UCL. The answer is yes. And you know, when I'm using it long-term, like any other medication, it's about weighing risk versus benefit. So, for example, in medical cannabis for anxiety, I really want to keep the CBD ratio very high and the THC content very low. It's not a cure for anxiety. I have had patients in the past referred to me who believed that when I really kind of dig down and find out what my patients understand about cannabis, because I find that if I don't get their understanding correct before I launch into how this is going to help them, then their treatment outcomes are not as good. So sometimes when we really drill down, they think that they're going to take this and it's going to cure their anxiety or cure their mood disorder. So we really have to reframe that, because it's not a cure. And like any other tool that we use as a treatment, if you withdraw the medication, generally the symptoms come back. There is one, I had recently had an interesting talk with a colleague about this. However, if you can reduce someone's state and trait anxiety using CBD, using cannabis, and they're able to engage in things that have been proven to have a brain change associated with them, like CBT, mindfulness-based stress reduction, it is possible that their state and trait anxiety over time goes down. But technically, it's not a cure.
No, fair enough. Thank you. What about this one? You've talked about people coming a lot with mixed symptoms. It's often not just anxiety, but supposing someone does just have anxiety, medical cannabis can work for that alone? And I've got a follow-up question.
Yes, the short answer is yes. And I have treated people with general anxiety disorder with medical cannabis. Again, high CBD, low THC.
Okay, but are there any circumstances where you wouldn't have any THC at all, or the tiniest bit?
So in Canada, the office of medicinal cannabis, they basically say what you can and can't prescribe on the medical side. Now, since October of last year, people have gone, it's gone like free for all, and people can get whatever they want walking into a dispensary, which is a whole nother topic that I have very mixed feelings about, because some of my patients have gone to a dispensary and got the wrong strain and been admitted for acute panic in the emergency room afterwards. But generally speaking, if I'm using a medical product in Canada, it's usually between 0.5% to 1% THC at a minimum, because it's made from cultivars of the plant that are considered on the cannabis side, not on the hemp side. That being said, people always want to know, well, what about hemp-based CBD, which has less than 0.2% THC? For mild anxiety, that can have an effect on people, a beneficial effect, and it is extremely safe. But for the types of clinical anxiety disorders that we're going to see in clinical practice, usually you need something a bit stronger, and the small amount of THC, the way that it works at those receptor sites that are in the limbic system, it can calm some of those fight or flight reaction networks. Without getting too technical, this is what we think is going on anyways at the CB1 receptor site, and that's the THC. And then when you bring on the CBD, it seems to kind of help enhance that effect without THC side effects. So if you use a low THC product, let's say 20 parts CBD to 1 part THC, it will not make someone feel intoxicated, but oftentimes it'll work better at a lower dose, which reduces the cost for the person.
Okay, thank you. What about, I mean, in the UK, whilst we are struggling to get prescriptions, the choices people have really are the CBD oils that they might get from the health shop or recreational. Is there any sort of way of finding some recreational where you know the ratio?
Yes. So I am in touch with all of the patient advocacy groups. Obviously, I don't want to name names because technically it's illegal for them to do this, but some of the patient advocates have a compassionate program where they grow a few plants for patients and then they get tested from third-party labs. So some of the patient advocates I've spoken to have actually started suggesting that they send samples to a third-party lab, and sometimes I get sent the lab reports from some of the samples. So yes, some people are testing their cannabis. The tricky part is that the seeds that they're getting and the type of cannabis they're growing, even when they're trying to grow higher CBD strains, sometimes it's a bit tricky. So if someone is accessing on the recreational market as a harm reduction approach, I would say to get in touch with patient advocacy groups here in the UK and the cannabis clubs. The cannabis clubs and the patient advocacy groups will often have a guy who tests their products at least, so you can have a way of doing some harm reduction. And also, really importantly for mental health, making sure they have not added any spice, which is synthetic cannabinoids, which binds very tightly to the CB1 receptor and we think might have an increased risk for psychosis.
On the subject of that, we've got several questions here about can medical cannabis be used for anxiety in people who have other mental health problems, such as bipolar or other?
Yes is the short answer, but I'm extremely, extremely cautious of the THC. So ideally, a product that is 0.5% THC or less. Some of my colleagues who specialize in psychosis, not in the UK, but in other parts of the world in my network, use it, and I've used it in a few cases like this in Canada for the side effects of the mood stabilizers and the antipsychotics, but very, very low THC products. That's where the CBD hemp products can be helpful because at least they're so safe as long as they actually are what they say they are on the tin. But yeah, with basically anyone who has a history of mania, bipolar, any psychotic disorder, even in a family member, I'm really not a fan of THC. Some of my colleagues have used it because they feel that if someone's not sleeping, even if they have a history of psychosis, they've tried everything else, adding some THC to help them sleep. I don't know, that kind of freaks me out a little bit. I haven't been so brave because there's some research that one of my friends is doing at Cambridge right now. Dr. Lilly, I'll send you guys her study, but basically how someone reacts to THC, it depends on our genes and our epigenetics. So you might give someone a little bit of THC who has a predisposition to psychosis, and if they form what's called heteromers with their CB1 receptor and the THC, that's someone who seems to have a higher disposition to going on to have a psychosis associated with cannabis. So we're still learning all these different factors that go into the cannabis and psychosis risk, and it's all about THC. So the risk basically is low as long as the ratio is high of CBD to THC, but it's still potentially there.
Okay, fair enough. Right, I've got 3 questions. All pretty much the same thing. Tony, Mohammed, and Angela are all asking about will CBD affect my current meds or the ratio. So drug interactions really, but especially with the CBD oils is the question.
So CBD oil, from a wellness perspective, the ones you're buying on the shelf without a prescription are very unlikely to ever cause any drug-herb interaction of clinical significance. Of course, all these things are metabolized through the cytochrome P450 system. There's certain ones that metabolize CBD that also metabolize other drugs. I've used it with so many drugs, like every drug under the sun, in amounts under 100 milligrams a day, very rarely. It's never been a clinical issue. Where I'm cautious is cancer patients on immunotherapy, especially with THC. I'm cautious with people on anti-epileptics, especially clobazam and CBD, but again, under 60 to 100 milligrams, you usually don't have a problem, but you want to monitor the drug levels just to make sure. And a lot of this is just being really careful. I'm just really careful. And the other category is the biologics in people with autoimmune disease. So, these are going to suppress the immune system. CBD has a slight immunosuppressant effect as well. You also potentially get better benefit when you mix them together, but you really have to monitor closely for symptoms of side effects from the biologics when you do that. So yeah, those are the categories to watch out for.
Okay, two more quick-fire questions before we let you go. But first of all, any risk of weight gain?
It's a really good question as well. So CBD generally is weight loss promoting. It does depend on some degree to the profile of the plant itself, like the other cannabinoids. Like THCV, for example, is an appetite suppressant. But high amounts of THC, especially certain cultivars, certain strains, seem to promote appetite in some people. So that is a side effect I'm always monitoring, especially with my patients with metabolic syndrome. We really don't want them to gain any more weight. So, we're trying to choose, again, high CBD products, low THC products to minimize that side effect.
Okay, yeah, low munchies.
Yeah.
What research are you relying on? You've talked about the RCTs being the wrong tool, but what studies? I mean, NICE have come out and said, pretty damning response about it. What would you want NICE to look at in their next review?
Maybe the evidence base, maybe going on PubMed. I mean, you're talking to someone who's going to be pretty scathing with NICE. I think, the problem with NICE is they looked at RCTs and they looked at a lot of meta-analyses that looked at recreational observational data, which is just really, really different from medical cannabis. And it's not their fault. They're trying to be good scientists. And, I'm critical in the sense that I don't think it's the best way to assess cannabis, but I'm not critical in the sense that I think they've done a terrible job, because that's the toolkit they're used to assessing drugs, for example. What I would like them to look at, and what we need more of, to be frank, is more evidence. And I've seen thousands of people in my practice, and there are hundreds and hundreds of studies on PubMed. A lot of them are preclinical. A lot of them are small n's, like small numbers. A lot of them have mixed samples. There's all kinds of problems with them, but it's the best we have right now. And what I feel is most of the other medications we use in mental health on a regular basis are often used off-label, like the antipsychotics for sleep. And there's loads of problems with that in terms of, benzodiazepines people are put on them for years, and we only have studies really on their safety for 6 to 8 weeks. So I think, we have to be conscious of that as well, that we've really singled out cannabis, but I'm the first to admit that we need more research, and to that end, I'm involved with a few projects that are trying to do that now in the UK.
Fair enough. Last question. You mentioned, I liked your line about no one said SSRIs are life-changing, but are there any sort of head-to-head studies? Can you compare SSRIs with medical cannabis?
No head-to-head studies. Good point. But the things that we're treating are the same. And you know what? People always say, to play devil's advocate, that I'm seeing a selected sample of patients who are refractory to treatment, and that is true. A lot of the patients I see have tried everything else, but I also get patients who, in Canada, it's not only you can use it as a first-line medication depending on patient preference. So I do have patients who just don't really want to try those things; they just want to go right to something more natural. Although we always have to have the discussion that natural doesn't always mean safer. I think that's also really important for people to understand. So I usually use a few examples where natural things are not safer, because I think it's just important to have a balanced argument, even if you're an advocate for medical cannabis.
Dani, you have answered all those questions so well and kept us really engaged. Let's just, Kate, could we actually return to that poll, the question about the, well, we've got two questions. Yes, do you think there is a role for treating anxiety with medical cannabis? Yes, no, don't know. And 5 seconds left. We're against the clock here. Okay. Oh, look at that. Doesn't that make you feel good? Yeah, and Okay, and if we could just lastly go to that last quote, the one that we started with, do you think it could cause problems? Okay, could we have that question? Yeah. Let's just see if there's any change on that one. Last 5 seconds. Whilst we're okay, that's great. And so that's still up there, but you have certainly done a good job at, so that's pretty equal there. My last job is just to encourage you to register for the next one. We've actually mentioned substance misuse several times in Dani's talk, and we got Nicholas Lintzeris, professor from Sydney, on medical cannabis and the treatment of drug and alcohol dependency on Wednesday, not Tuesday, 20th of November at 7 p.m. We'll give you details on that, and it will be on the website. Don't forget the RCGP SMMGP conference, end of January 2020. Think about My Medic Learning. That's a really good sort of e-learning program. Please fill out an evaluation following this webinar, because that really helps us. Lastly, you do get the opportunity for SMMGP premium membership, and if you've enjoyed this, then there's some fantastic webinars coming up. Andre Giel on problem gambling, Owen Bowden-Jones, Chem Sex, Emily Finch on complex alcohol problems. Phew. Lastly, I want to thank you, the audience, for being great and contributing. I want to particularly thank Dani Gordon for a fantastic talk. Thank you, everybody.